Okay, I think we'll make a start. Good evening, everyone. Welcome to tonight's webinar that East Melbourne PHN is hosting on behalf of Kidney Health Australia. The topic for tonight is early detection and management of chronic kidney disease. I'm Stephanie Lenko, and on behalf of Eastern Melbourne PHN, I'd like to thank you all for joining us tonight. We'd like to acknowledge and thank the traditional custodians on whose unceded lands we gather this evening. I acknowledge that I'm working on the lands of the Wurundjeri people of the Kulin Nation. I wish to pay my respects to elders past, present and emerging, and I acknowledge that the Aboriginal and Torres Strait Islanders are the first peoples of Australia. Just some housekeeping for tonight. Everyone will be on, all attendees will be on mute throughout the webinar. So your questions, please ask any questions through the Q&A box. We'll answer any questions that don't get answered throughout the presentation will be answered at the end of the presentation, and the webinar will be recorded, so you'll be able to review it down the track. You'll also be sent a copy of the PowerPoint slides and your attendance certificate and a link to that video recording in about 7 to 10 days. So hopefully you've had a chance to peruse the case study a little bit and have had a go at answering some of those questions. This case study is going to be featured in tonight's presentation, and we'll be using polls to do that. And just an upfront reminder that we do love you at the end of the session to complete that evaluation, because we really value your feedback. So we'll remind you at the end again, but yeah, that would be really appreciated. So on that note, I'd like to welcome our guest speaker for tonight, Annette Besant. Annette's an experienced practice nurse, nurse practitioner at Monash Health Nephrology. She works with a multidisciplinary team to ensure that patients at all stages of chronic kidney disease receive timely and effective care. Annette has a special interest in slowing the progression of CKD and improving the patient care journey, particularly for those people with complex needs. Thanks, Annette.
Thanks, Stephanie, and thanks everyone from Eastern Melbourne Primary Health Network for having me along tonight. And I pay my respect to elders past and present and extend that respect to all Aboriginal and Torres Strait Islander people today. I'd also like to acknowledge the Primary Care Education Advisory Committee for Kidney Health Australia, the PEAK committee, who have developed and reviewed this education, and to our sponsors. So what I'll walk you through tonight in terms of learning outcomes will be outlining the importance of early detection for those at risk of chronic kidney disease, describe the elements of the assessment for a chronic kidney disease kidney health check, and I'll define the treatment options to delay progression of kidney disease and hopefully halt it in some of your clients. So first of all, just to help you understand a little bit better how we define CKD, there's two ways that we come up with a diagnosis of chronic kidney disease, and that will be an estimated glomerular filtration rate of less than 60 mL per minute that's present for greater than 3 months with or without any associated evidence of kidney damage, or evidence of kidney damage with or without a reduction in the GFR, but again, it must be present for 3 months, irrespective of what the underlying cause might be, such as albumin in the urine, hematuria after the exclusion of a urological cause, any structural abnormalities, such as those that might be seen on the various imaging tests, or any pathological abnormalities, such as those that might be found under a renal biopsy. So we're going to come along to our first poll, and hopefully everything goes smoothly for this. Steph is going to be helping me along with this. And yes, Stephanie, I can see that poll come up on my screen.
Excellent. So we'll give you about 20 seconds to try and answer this question. Okay, any other answers? Anyone else placing an answer, having a bet? Okay. So sharing the results. Can you see the results, Annette?
I can see the results there. And so can we stop that sharing now? Thank you.
Yes. Yes.
Yeah. I can still see the screen there. I'll move on to my next screen. So most respondents have guessed 1 in 20 Australians with CKD. And I'm not able to move on to my next slide while that poll's up on the screen.
Okay, is that gone?
No. That is now. I've got it. Yep. However, my screen will not move. There we are. So 1 in 10 Australians, adult Australians, having chronic kidney disease, but an increased prevalence of 1 in 5 Indigenous Australians having indicators of chronic kidney disease. And just to talk through that in a little bit more detail, up the top of this graph, 26,000 or thereabouts people having end-stage kidney disease, and another 60,000 with stage 4-5 kidney disease. These are the population that I predominantly care for. Below that, there's another approximately 2 million people who have kidney disease, but unfortunately, less than 10% of those people are actually aware that they have the condition. So many, many millions of people, or hundreds of thousands of people out there, completely unaware that they are living with a chronic condition. And furthermore, another 5 million at risk because of having a diagnosis of hypertension or diabetes. And I'll come back to this slide towards the end of the presentation, just as we tie everything up and reference some of those figures again. What that all means is that CKD really is a major public healthcare problem, although it doesn't get, I guess, as much of the publicity as some of the other things that you might see out there in public health messaging. But with 1 in 10 Australians with chronic kidney disease, and less than 10% of those people knowing that they have the condition, and with cardiovascular disease being a major risk factor with the condition, it's really important that we're picking them up because the disease is common, it's harmful, and it's treatable. The big reason why most people are unaware that they have the condition is because 90% of kidney function can be lost without any symptoms being experienced. In terms of the causes of kidney failure in Australia, the graph on the left-hand side shows you all adults over 18 years of age. Since 2003, diabetes has been and continues to be the leading cause of kidney disease in Australia and in fact around the world. When we add that to the second most common cause of kidney disease being high blood pressure, along with adding in some of the other causes that are preventable. So 50% of the adult population have kidney disease as their primary cause, and the statistics reach as high as 45% in the Aboriginal and Torres Strait Islander population. So we'll move on to our case study, Audrey. Audrey is 63 years old. She's an accountant and she has a history of mild asthma. And she's a new patient to the practice. Audrey has a past medical history of overweight or obesity with a BMI of 31, some mild intermittent asthma, chronic low back pain, mild hypertension, and she also has a family history with a maternal grandmother who died of a heart attack in her 60s and a history of kidney problems, but she can't be more specific, and a mother who has type 2 diabetes and a father with angina and hypertension. Audrey reports that she's a smoker of 20 to 25 cigarettes per day. She consumes 1 to 2 glasses of wine on 3 to 4 nights per week. No known allergies, and she takes some salbutamol inhaler as she needs for her asthma. So does Audrey have an increased risk of chronic kidney disease? And we'll come to a poll question.
Hopefully it's sitting there. Okay, 2 more seconds. Any other answers?
Why is this not? It seems to be with the poll, we have trouble. There we go. In terms of the risk factors for kidney disease, the risk factors that are well known and established are having diabetes, as we mentioned, being the leading cause of kidney disease in Australia and the world, having high blood pressure, having an established history of cardiovascular disease, having a family history of kidney failure, being obese or overweight with a BMI of more than 30, a history of smoking, being 60 years or older, but age in itself is not an exclusive risk factor. It must be in conjunction with one of the other risk factors, and a history of acute kidney injury. And Audrey fits into 4 of these groups with her high blood pressure, her weight, her smoking status, and her age. Overall, in the country, 1 in 3 Australian adults are at risk of increased risk of chronic kidney disease. High blood pressure being a second most common cause of kidney disease, but also a manifestation of having the disease itself, is a very problematic aspect of our management strategy. The kidneys are essentially a bundle of microscopic blood vessels, and high blood pressure can certainly and does damage those small blood vessels that are in our kidneys. The damaged vessels can't filter the waste products in the way that they normally should. By having damaged blood vessels, we then hang on to the waste products, which causes further damage, and we've got this ongoing problem of damaged kidneys causing high blood pressure and high blood pressure damaging kidneys. And so therefore it can make blood pressure management a real challenge in the population, and we may see people who are on 4, 5 or more agents to try and achieve a target blood pressure control. Obesity. So people who are overweight are 80% more likely to develop kidney disease. And we do know that abdominal adiposity is more important than a generalized obesity. So sometimes using that waist circumference is a very useful tool. It's not as powerful indicator of risk as what diabetes or high blood pressure is, but certainly overweight people are more likely to develop albuminuria or protein in the urine, and this is toxic to the kidneys. And losing weight can certainly improve glycaemic and blood pressure control independently, therefore reducing those other risk factors. Smoking. So the AusDiab study was a longitudinal population-based study which examined the prevalence and the incidence of diabetes and its complications in around 11,000 adults. And it was initially done around 1999 to 2000, and then there was a couple of follow-ups around 5 to 6 years later, and then 10 to 12 years later. What it found, that smoking and the longer the smoking history that there was, increased the risk of kidney damage. And that smoking history also, once again, increased the risk of albuminuria and proteinuria, which subsequently would accelerate the loss of kidney function, or what we know as the GFR. Age, as I mentioned, in itself is not an independent risk factor, but this is in conjunction with the other risk factors mentioned. And the reason for this is that once we reach 40, we all naturally start to lose around about 1 ml or just under of kidney function each year. So over each decade of our life beyond 40, we lose naturally around 5 to 8 mils per year. So as we age beyond that 60 margin and beyond, we're already down to a GFR of perhaps around 60 or so, 60 to 80, and then that will continue to decline. So another poll we have here, what are the elements of a targeted assessment for CKD in at-risk groups, such as those that we've identified Audrey to be in? So this is a tricky, it's a bit of a wordy question, but just give it a go. And you can pick multiple answers here. I don't think we've got multiple answers to pick from on our poll.
Uh-oh. Maybe we've got the answers on our poll. So we had it. Okay, so we've got 60% have chosen the creatinine and the eGFR. Nobody has chosen the blood pressure that I can see. 40% have chosen the urine albumin to creatinine ratio, and nobody has chosen imaging or the urine protein to creatinine ratio or the urine dipstick, because those options are not there. So I'm just going to close this down and hopefully we'll be able to move our slide on and not have it frozen. There we go. So correctly, the elements that we use to monitor or assess at-risk groups are the serum creatinine and the eGFR, a blood pressure measurement, so that's equally important as part of that check, and the urine to albumin to creatinine ratio. So we're using the 3 tests in conjunction to make our assessment and our diagnosis. And we'll talk through each of those in a little bit more detail. So, as I mentioned, the blood test or the eGFR, which is using the serum creatinine, the urine test, which is a spot urine test to check for protein or albumin, the smallest and most abundant form of protein in the urine, and the blood pressure to assess if it is above or below target. And everybody who's in an at-risk or has been identified at risk due to the risk factors that we previously mentioned should have a kidney check at least every 2 years. But for people who have a diagnosis of diabetes or hypertension, that should be annually. So the GFR, what is it? It is the best way that we have to measure kidney function. If the kidneys are not working well, then the levels of creatinine in the blood rise. Creatinine is the byproduct of protein and muscle metabolism, and it's freely filtered through a normal healthy kidney. So when the kidney is not working well, the levels naturally rise. We don't have an effective way to directly measure the kidney function itself. So the creatinine is the closest by a measure that we use. And we do this using a complex prediction equation. As I'm sure most of you would be familiar with, it's automatically generated whenever an electrolyte pathology request is done by any lab in Australia these days. The GFR looks at how well the body is removing the waste products, such as creatinine. But it is also measuring other products as well, or we're also aware that it's measuring other products. If we needed a more specific measurement, we could revert to a 24-hour urine collection, but it's very rarely done these days because it's complicated and cumbersome for the patient.
And we can also look to imaging tests, nuclear medicine imaging tests, but by far the cheapest and most readily available test out there is the eGFR. A normal GFR in a healthy adult is greater than 90 mils a minute. 60 to 90 mils a minute is really not considered to be abnormal unless we can see evidence of kidney damage, such as the structural or the protein in the urine, etc. And if we see someone with a consistently lowered eGFR of below 60 mils a minute, then that is clearly indicative of chronic kidney disease. We have to be careful when we interpret the results that we see. Results where we might find that a misleading answer when somebody's had an acute change in kidney function. For people who are on dialysis, we no longer use that measurement. If people have exceptional dietary intakes, such as extreme vegetarian diets, extremes of body disease, the diseases of skeletal muscle, as creatinine is a measurement of creatinine or being a muscle byproduct. So when there's changes to an average muscle mass, then that will impact the result. It's not a validated tool for children under 18 years of age. If there's severe liver disease present, some medications can impact upon the creatinine excretion, or if we see values above 90 mil a minute or in pregnancy. In terms of the urine testing, many of you may be familiar with having done dipsticks in the past, and it's certainly not the recommended way of measuring for protein in the urine now. Our preferred method is for the spot urine albumin to creatinine ratio, and it's preferred to be on a first void specimen, but if somebody turns up to your practice and it's during the day and it's an opportunistic time to be able to receive a specimen from them, then that's perfectly fine. And if you can follow that up with an abnormal result with a first morning void, then that would certainly be a preference to move forward with. We know that there's an association between albumin in the urine and progressive kidney disease, and that as the amount of protein in the urine increases, so does the risk of complications. Microalbuminuria is picked up on a urinary ACR or an albumin to creatinine ratio. It might not be picked up on a protein to creatinine ratio, and hence why we use the UACR. Also, if we were to dipstick a urine and find protein on a dipstick, we've well and truly missed the mark to pick up the albumin loss in its very early stages and implement our early management strategies. And of course, we want to catch things early so that we can apply those therapeutic interventions early. Cardiovascular risk is associated, it can be used or monitored according to the level of an ACR or the level of protein loss in the urine. And by reducing the level of protein loss in the urine through the use of medications, we can protect the kidney and we can gain cardiovascular benefit as well. So as I mentioned, the ACR should be repeated on a first void sample if the results are positive, and certainly if you have a non-first void sample. You can use a point of care testing piece of equipment that you might have in your practice, but if that picks up a positive result, we would certainly recommend that a lab specimen is sent away for formal quantification. And albuminuria is considered to be present if at least 2 of 3 tests are abnormal, including that initial test. And CKD, remembering back to that diagnosis, there was the 3-month defining marker. So if albuminuria is present for at least 3 months, then a diagnosis of CKD can be made. And I mentioned about why we no longer use the dipstick being not sensitive or specific enough for our circumstances. So back to Audrey. and our case study. Because of her risk factors, you've determined that Audrey should have a kidney health check. If her results are negative for chronic kidney disease, she should have a kidney health check every year because she has got high blood pressure. She's had her kidney health check. You've done her blood test, her urine test, and her blood pressure. And these are what her results are. So a normal creatinine being less than 115, and she's got a slightly elevated creatinine of 118. A normal eGFR, as we mentioned, being above 90, and Audrey's has come back at 55. So you can see that with the very slight increase in the creatinine, there's actually a substantial change in what that eGFR is. And that's why we don't use the creatinine as the measure of GFR. Quite a substantial amount of kidney function can be lost before we see a significant rise in the serum creatinine, in fact, over half. 3.5 milligrams per millimole of protein or albumin in the urine, and Audrey's is above that range at 5.7. And her blood pressure has been measured at above a target range of 130 on 80, being 155 on 95 millimeters of mercury. So do Audrey's kidney health results mean that she has chronic kidney disease?
Results are coming through. That's good.
Yes. Yeah.
A few more seconds. Anyone else going to have a try? Okay.
Okay, so we've got 33% saying yes, she does have kidney disease, and 67% saying that she may have kidney disease. So our answer to that question is maybe. And the reason for that is because, remember back to the 3-month time frame, to diagnose Audrey with chronic kidney disease, the protein in the urine, or the ACR, and the GFR need to be repeated at least twice over a 3-month time frame, and preferably on an early morning urine specimen, to be able to have an accurate diagnosis. But because Audrey's GFR had come back at 55 mils a minute, we do recommend that if that initial sampling does come up with a GFR of less than 60 mils a minute, you should repeat it within 7 days. The reason that we want that done is because number one, we want to make sure that there's something not more urgent going on, and that we have got that stability and time to be able to wait the 3 months. Also, there's factors that can be known to increase the urine to albumin excretion, and these might be a transient issue or a more long-standing issue. So we really need to sit it out for that 3-month time frame to come up with our diagnosis. So a UTI, of course, that's treated. We might see the urinary albumin disappear. Congestive heart failure, an acute febrile illness. If someone's exercised very heavily within the last 24 hours, then that can certainly make them have an increased ACR. If there's any kind of genital discharge, and certainly some medications that can cause increased albumin excretion. So your GP and you together would be working through these things with your patient. So Audrey does come back 3 months later with her repeat tests, the ACR, the GFR, and you've checked her blood pressure. And these are the results that you see on her first, second, and third visit. So you can see that she still has a GFR that is reduced. It's dropped down a little bit further to 52 mils a minute. Her ACR, being 8.4 milligrams, has increased slightly from the initial assessments, as has her blood pressure, because I'm assuming for some reason, and I can't explain why, that we haven't put her on a blood pressure lowering agent at this particular point in time. So Audrey has now got the indicators to give her a confirmed diagnosis of what we call CKD stage 3A. So CKD is staged 1 to 5, and the A and the B helps us to further quantify where her risk is, because this impacts on our management strategies. And we always indicate as part of our diagnosis if a person has micro or macro albuminuria, because as you can see by this staging grid, we have green, a traffic light kind of system. I'm sure you'd be familiar with other diseases and similar traffic light systems, but it places the management into low, medium and high risk management strategies. And that's based on what that kidney function is, as well as what the level of protein leakage through the urine is. This then gives you an action plan to be able to work within your practice and with Audrey to optimise her care, which will hopefully help you to delay or slow the progression of her disease. And of course, that's a really important thing for Audrey, because as well as slowing progression, you can help work with her to prevent the complications, which we'll talk through a little bit more, but predominantly reduce her risk of cardiovascular disease and reduce her risk of morbidity and mortality from other causes. And certainly what we know, that picking these up early and implementing the appropriate treatment strategies will and can reduce the rate of progression by up to 20 to 50%. This is a very busy slide, and I'm not going to talk through it all, but in the Chronic Kidney Disease Management in Primary Care booklet, which is available electronically or in hard copy, or there is an app-based tool to be able to use, it gives you the exact goals of management and the strategies that you would be working with Audrey on to improve her risk factor and her lifestyle, her management of her disease. So you would be, in this instance, with a 3A with microalbuminuria, calling her back every 3 to 6 months, looking at the blood pressure, her weight and her smoking status, and working on strategies with her to reduce those, as well as the laboratory assessments such as the ACR, the eGFR, other biochemical profiles such as the urea, the creatinine and the electrolytes. If she was a diabetic, an A1C, lipid profile, the full blood count, because this can be impacted quite significantly in someone with kidney disease, as well as the mineral markers and other hormones, which are commonly deranged in people with kidney disease. It also gives you some step-by-step guides on other assessments that you can implement as part of her plan of care at various stages along her trajectory. So now that Shirley has a diagnosis of chronic kidney disease, what would you think are the various management elements that will be important for her care moving forward? And can't see, there we go.
Yep. Few more answers coming through. Okay.
So we've got most people choosing blood pressure management. Nobody has chosen lifestyle modification, nobody cardiovascular risk reduction, trying to delay disease progression 40%, and referral to a nephrologist, nobody has selected. So the management elements that we strongly encourage you to work on with Audrey would be lifestyle modification, blood pressure management, cardiovascular risk reduction, and those efforts to delay disease progression. And I'm mindful of the time, so I may just speed up a little bit. So pardon me if I speak a little bit quicker. So lifestyle modifications are really important approaches that are the mainstay or backbone of what we do to reduce cardiovascular and other risk. This is focused on the SNAP principles, so encouraging Audrey, I should say, to stop smoking, working with her on a diet specific to her needs to reduce the BMI, low salt diet, very important to help reduce blood pressure, encouraging a reduction in alcohol intake and more physical activity for her to help reduce that adiposity that she has, or weight reduction. Lifestyle modification is a really good opportunity to work with your patient on self-management and motivation. We know that if a person is really motivated to be engaged in their self-management, then we have, you know, really positive outcomes. It's not just about pharmaceutical targets, etc. And there's lots and lots of resources that are out there for you to be able to link into. There's other healthcare professionals through GP healthcare plans. There's the community resources that are out there, the various support groups, social groups that are out there, lots of skills and support programs that can be accessed online these days. The opportunities are really endless out there. The lifestyle modifications, very busy slide again, but it's a great one. And it's an old one now, but really well studied. By bringing weight down can have a significant reduction in a blood pressure target alone. Diet restriction of sodium, Western diet, everybody has a high salt diet. And reducing the sodium intake in a diet can certainly have a significant impact on blood pressure reduction. Diet that's essentially the Mediterranean diet, still very popular, high in fruit and vegetable, low in saturated and total fats, very strong association with blood pressure control and improvements. Getting out there, getting physically active, blood pressure reduction, and alcohol consumption in moderation, again, a small reduction in blood pressure reduction. For all people who have chronic kidney disease, we're targeting a blood pressure of below 130 on 80, except in certain circumstances where it may be inappropriate to aim for that target, such as somebody who's very frail, perhaps elderly with diabetes and poor autonomic function. And if they stand up, the blood pressure drops too low, so we have to be a bit more lenient. Or for a younger person who's got you know, really a long lifespan ahead of them, it might be appropriate to aim for a more stringent target. If we get a really good blood pressure control of 130 over 80 or less, we're going to see a very minimal decline in the GFR, in line with that normal aging of, you know, sort of around about 1 mil a year or perhaps a little bit more. The poorer the blood pressure control, or moving across to the right of the screen, the greater the chance of a progression of the kidney disease. So if Audrey's blood pressure stays around the target where it is now of 100, or the range where it is now of 160 over 95, she's going to lose 10 or 11 mils of her kidney function per year. She's going to be at end-stage kidney disease and needing kidney replacement therapy rather quickly. Blood pressure reduction is associated with a reduction of cardiovascular risk. And cardiovascular risk is high, very high in someone with chronic kidney disease. So we really want to get that blood pressure down to target. Renin-angiotensin system blockade is the first line of therapy, or so an ACE or an ARB, especially for people that are losing protein through the urine. We don't use the two of them together. I've never seen that in all my years of practice. But for some people, for various reasons, they're not able to tolerate these agents. So any of the blood pressure agents to get that blood pressure target are helpful, and in conjunction with those lifestyle changes that we mentioned. So Audrey has chronic kidney disease. What do you think about her CKD diagnosis and cardiovascular disease? Is she already at high risk? Is high blood pressure an indicator of a future event? Is chronic kidney disease more important risk factor than cardiovascular disease? Or do people with chronic kidney disease have a 2 to 3 greater risk of cardiovascular death than people without? And you can pick several answers there.
A lot of words to read on that slide.
It is a lot of words to read. So we've got a good range of choices across A, C, and D. And we'll just move on to our answer.
Oh,
Oop, what happened there?
am I sharing the answer still?
I put them away. So everybody was right there. A, C, and D are the correct answers. She's already at high risk because chronic kidney disease is a more important risk factor than diabetes. And people with chronic kidney disease do certainly have a 2 to 3 greater risk of cardiovascular death than people who don't have chronic kidney disease. In fact, people with a GFR of less than 45 mils a minute or who have diabetes and microalbuminuria are greater than 60 with diabetes have established cardiovascular disease or familial high cholesterol or uncontrolled high blood pressure, are certainly at the highest risk of a cardiovascular event. And so the cardiovascular risk calculators that are out there should not be used. They should automatically go into the highest management strategy. And this includes lipid lowering. So of course, that was part of our management plan. Her lipids should be assessed. And we should also be monitoring her glycaemic control or monitoring for the presence of diabetes or the development of diabetes. I'll skip over this particular slide because it's really touching on what we've done, and it's saying again that the risk is high because of that presence of chronic kidney disease, but it overlays with each of those other conditions. A little bit about the SGLT2 inhibitors. I'm sure that you're seeing a lot of these coming into your practice setting. All of the trials that are out there are showing an incredible benefit in terms of protecting the kidney and protecting the heart when using an SGLT2 inhibitor for people with diabetes. But over the last couple of months, the PBS has now made available dapagliflozin for use in kidney disease alone or in someone with heart failure. So you no longer have to have a diagnosis of diabetes to be prescribed these agents, because we know that they have great benefits in protecting renal function and protecting the heart. It's also opened up opportunities for more broad prescribing for people who do have diabetes in terms of some of the agents that we couldn't easily prescribe together previously. One of the things that is really important for you guys in practice land is to always ensure that, similar to diabetes and having a sick day management plan, I would always encourage you that a person with CKD should have a sick day management plan. So similar to someone with diabetes, if they're having in particular a dehydrating or a febrile type illness, and I do spend a lot of time talking with my patients about this, a plan to temporarily cease some of their medications and not to recommence them until they've been assessed in the practice, because this can certainly exacerbate not only some of the complications of diabetes if they have that, but can exacerbate an AKI. So if we're using the SADMANS acronym, that gives you the clue to what medications you should be looking at and discussing with your patient about what to do in the presence of an illness, and papers to help or handouts to help them know what to do can be printed off the Kidney Health website. It's really important that you know that your person has a diagnosis of CKD, because the treatment targets and the therapy choices certainly can differ if they do have that diagnosis. And if you've picked it up early and you've implemented the various management strategies, then prognosis can and will be better. And there's also some medication issues to consider. So, you know, many medications need dose adjustment depending on the stage of kidney disease, or are inappropriate, and or they can be nephrotoxic. So in your practice, there are the integrated care and various management plans. There's the Chronic Kidney Disease Management Guidebook. There's the practice data to help you identify the at-risk groups. You can code and stage using your practice software. You can implement a register and a recall system to screen and manage your patients. And you can work closely to support and assist your patients on particularly with those self-management strategies. And anyone who might be newly diagnosed and wanting more information is more than welcome, or please direct them to the Kidney Health Australia helpline, and there'll be someone at the end of the line to help guide them or yourself through. So the take-home messages: CKD is common, it's harmful, and it is treatable, but we need to know about it. Remembering that 90% of kidney function can be lost without experiencing symptoms, so we need to identify the risk factors and then progress from there with the testing. Early detection is beneficial. Know who those at-risk groups are and perform that kidney health check when it's indicated. So the urine test, the eGFR, and a blood pressure check. Maintain that blood pressure consistently below the target range, and use the staging table to help you develop an action plan for your patient. And remember back to that pyramid at the beginning, when I said that most of those patients at the tip of the pyramid are the ones that I see, and the other 2 million plus the extra 5 million, they're the ones that are out there in primary care land. And most of these can be managed really well in the practice before the need to come and see us in the specialist setting. So thanks for listening, and really happy to take any questions.
Okay, there's no questions at this point in time. Did you want to put up the QR code for the evaluation whilst we are waiting to see if there's any questions?
Certainly, and just as I move through, so again, the link to the resources, if you just would type in Kidney Health Australia in your search engine, and then it's quite a comprehensive site. So there's plenty of bits and pieces that you can look through there to find. If you did want a copy of the booklet, you can download a free copy, again, via the Kidney Health Australia website, or certainly hard copies can be purchased for your practice, or the CKD app is what I also mentioned earlier. And here is the QR code for the feedback link. But thank you again for having me, and happy to take questions on or offline.
Okay, we'll wait to see if there's no questions at this point yet. If there are any questions, if you type them in the Q&A box, that would be great. In the meantime, thanks, Annette, for sharing your knowledge and experience with us. But certainly your presentations provide us with much food for thought on the things to consider and the opportunities available to limit CKD in patients. And with the 5 million people in Australia that are sitting in waiting rooms, I'm sure there are many there that are undiagnosed with CKD at this point. As far as all you participants, thank you for joining us again at the end of a day's work, probably. Apologies for our internet glitches during the presentation. Yeah, it worked out better towards the end there, so that was good. We'd appreciate if you would fill in the short evaluation either through this QR code using your phone, or when you sign off, there will be the same evaluation will come up automatically. You only need to do one or the other, not both. So yeah, I'll just check for questions. There are no further questions. I think you must have answered everything well. Thank you, Annette. So as mentioned, the webinar has been recorded, so it'll be available and you'll be notified when it's available on the Kidney Health website. And we look forward to seeing you at another event in the future. Have a good night, and we've got 5 minutes spare. You can go and have your dinner or do whatever. Thank you.
Thank you.
Bye now.